Amlodipine versus metoprolol. Which blood pressure pill is leaving you tired after 60? If you're over 60 and taking a blood pressure medication, I want you to ask yourself a question before we go any further. When was the last time someone actually explained why you were prescribed the specific pill sitting in your medicine cabinet right now instead of the other one? Because there are two medications that make up a huge share of blood pressure prescriptions for people over 60, amlodipine and metoprolol. They are both extremely common, they are both effective, and they work in completely different ways inside your body. Most people taking one of them have never been told why that one was chosen over the other, what it's actually doing inside them, or what warning signs they should be watching for as their body ages around that daily pill. That gap in understanding is what we're going to close today. Not by telling you which drug is better, because that's not actually a real question, but by giving you the same depth of understanding a good specialist would want you to have, so that the next time you sit across from your doctor, you're not just nodding along. You're actually part of the decision. Let's start with something that almost never gets explained clearly, and it's the single most important piece of context for everything that follows. Your body at 65 is not your body at 45. That sounds obvious, but very few people understand what it actually means for how medications behave once they're inside you. It's not just that you're older, it's that several of your organ systems have quietly changed the way they process everything you swallow. After the age of 60, your artery walls gradually lose elasticity. They become stiffer, less able to expand and contract the way they did decades earlier. This has a very specific consequence. It becomes harder to control your systolic pressure, which is the top number in your blood pressure reading. That number matters enormously because it's the one most closely tied to stroke risk, heart attack risk, and even long-term cognitive decline. At the same time, your liver, which is responsible for breaking down almost every medication you take, slows its processing speed. A dose that moved through your system efficiently at 55 can behave very differently at 73, even if nobody has changed the prescription. Your kidneys filter more slowly as well, which affects how quickly certain drugs clear your system. And your nervous system becomes slower to respond to sudden shifts in blood pressure, which is part of why standing up too quickly can make an older adult lightheaded or unsteady, when it barely registers for someone younger. None of this means these medications are unsafe. It means the same medication, at the same dose, can behave differently in an older body than it did in a younger one. That's the lens we need for everything that comes next. There's one more piece of this puzzle that deserves attention before we get into the specifics of each drug, and it's the role of body composition. As we age, the ratio of muscle to fat in the body naturally shifts, even in people who stay active and maintain a healthy weight. This matters because some medications are stored differently in fat tissue than in muscle, which can change how long a drug lingers in the system after it's taken. Combine that with slower kidney filtration and a slower liver, and you start to see why a dose that felt perfectly comfortable for years can suddenly start producing side effects that weren't there before, even without any change to the prescription itself. This is sometimes called age-related pharmacokinetic drift, and it's one of the most overlooked reasons why a medication that worked fine for a decade can start to feel different in your 70s. This is also why routine follow-up appointments matter so much more as you get older. A prescription that was carefully calibrated for you at 60 may genuinely need to be revisited at 70, not because anyone made a mistake, but because your body has continued to change in the years between those two appointments. Let's talk about amlodipine first, because understanding how it works is the only way to judge whether it makes sense for you. Amlodipine belongs to a class of drugs called calcium channel blockers. The name sounds technical, but the concept is fairly simple once you break it down. Every time your heart beats, calcium flows into the muscle cells that make up your artery walls, and that calcium causes those walls to tighten. That tightening is a major part of what creates blood pressure. Amlodipine partially blocks that calcium from entering those cells. The result is that your artery walls relax. They widen slightly, blood moves through with less resistance, and your blood pressure comes down. For older adults specifically, this mechanism has a particular kind of relevance. Remember what we said about arteries stiffening with age. Amlodipine works directly on that stiffness. It targets the exact mechanism that makes systolic pressure so stubborn to control in people over 60. This is a large part of why it consistently shows up near the top of treatment guidelines for older adults with high blood pressure and no major underlying heart disease. The dosing detail matters here too. In younger patients, doctors often start at 5 milligrams daily. In older adults, many physicians prefer to start lower, often at 2.5 milligrams, and increase gradually over 1 to 2 weeks, watching closely for how the body responds at each step. This isn't excessive caution. It reflects the reality that an older liver processes the drug more slowly, and that blood vessels in an aging body can react more strongly to changes in pressure. It's also worth understanding what a typical monitoring schedule looks like once you start this medication, because knowing what to expect can help you tell the difference between a normal adjustment period and something worth calling your doctor about. In the first few weeks, it's common to check blood pressure at home a few times a week, ideally at the same time of day, seated, after resting for a few minutes. Some mild swelling in the ankles by the end of the day is common and often manageable with small adjustments like elevating your feet in the evening or reducing salt intake slightly. But swelling that's severe, that doesn't improve overnight, or that's accompanied by shortness of breath is a different matter entirely, and that combination should prompt a call to your doctor rather than a wait-and-see approach. Now let's turn to metoprolol because it works through a completely different pathway, and understanding that difference is what separates a passive patient from an informed one. Metoprolol is a beta blocker. Unlike amlodipine, which relaxes the blood vessels, metoprolol acts directly on the heart. Your heart has receptors called beta-1 receptors that respond to adrenaline. Every time you're stressed, physically active, or even just standing up quickly, adrenaline tells those receptors to make your heart beat faster and with more force. Metoprolol blocks that signal. Your heart rate slows down. Each beat becomes less forceful. And because the heart isn't working as hard, the pressure inside your blood vessels drops as a result. This mechanism is particularly valuable for a specific group of patients: people who have already had a heart attack, people living with heart failure, people managing certain irregular heart rhythms. For these patients, metoprolol isn't just lowering blood pressure, it's reducing how much oxygen the heart muscle demands, which can be genuinely protective for a heart that's already under strain. But the dosing caution here is serious. In older adults, doctors typically start at a notably lower dose than they would for a younger patient, often in the range of 25 to 50 milligrams of the extended release form, and they increase it slowly, with regular monitoring of heart rate along the way. And there's one rule around this medication that deserves your full attention. Metoprolol should never be stopped suddenly. Abrupt discontinuation can trigger a rebound effect, a sudden spike in heart rate and blood pressure that can bring on chest pain or a serious cardiac event. Any change to this medication, increasing it, decreasing it, or stopping it, needs to happen gradually and under a doctor's supervision. Monitoring on this medication looks a little different from amlodipine because the focus shifts toward heart rate rather than swelling. Many doctors will ask you to check your pulse periodically, particularly in the first few weeks after starting or adjusting the dose. A resting heart rate that drops below roughly 50 beats per minute, especially if it comes with dizziness, unusual fatigue, or a feeling of faintness when standing, is worth reporting promptly rather than waiting for your next scheduled visit. It's also worth knowing that metoprolol can blunt the normal rise in heart rate you'd expect during exercise, which means your usual sense of how hard you're working out may not feel accurate anymore. This isn't dangerous on its own, but it's useful to know, particularly if you use heart rate as a guide during physical activity. So now that you understand how each of these drugs actually works, let's put them side by side, because this is where it becomes personal. I want to walk you through a hypothetical situation. Not a real patient, just an illustration of how this plays out in practice. Because these kinds of experiences are common enough that most people managing blood pressure in their 60s or 70s will recognize some version of it. Picture someone in their late 60s who has been on metoprolol for a few years. Over time, they start noticing a persistent heaviness, fatigue that doesn't lift with rest. Their doctor, after reviewing their full picture, decides to transition them to amlodipine instead. Within a couple of weeks, that fatigue lifts noticeably. They feel more like themselves. But a few weeks later, they notice their ankles are swelling, tight enough that their usual shoes don't fit comfortably anymore. This illustrates the central truth of this entire comparison. Neither drug is universally safer than the other. Each one carries its own distinct set of side effects, and those side effects affect different people differently, depending on their individual health picture. Amlodipine's most common side effect is peripheral edema, which means swelling in the ankles and feet. This happens because the drug relaxes the arteries more than it relaxes the veins, so fluid tends to pool in the lower body under the pull of gravity. This isn't a sign of heart failure or kidney damage on its own, but it can be uncomfortable, and for older adults already managing balance concerns, added swelling and heaviness in the legs can become a real practical issue. Some people also experience facial flushing, mild dizziness when standing, or occasional palpitations. Metoprolol's side effect profile looks quite different. Fatigue is the most frequently reported complaint, often described as a kind of heaviness or loss of drive that colors the entire day. It can also slow the heart rate below a comfortable range for some people, leading to lightheadedness or, in some cases, fainting. And in older adults with certain lung conditions like COPD or asthma, it may restrict airways even at moderate doses, which is an important detail your doctor needs to know before prescribing it. Now let's talk about something that I think is genuinely one of the most underappreciated risks in senior healthcare, and it has very little to do with which specific drug you're on. It has to do with everything else in your medicine cabinet alongside it. The average adult over 65 takes 4 or more prescription medications regularly. Many take 6, 8, or even more. Each one may have been prescribed by a different doctor at a different point in time, evaluated on its own as safe. But medications don't exist in isolation once they're inside your body. When several drugs share the same processing pathways, they can start interfering with one another in ways that quietly change how each one behaves. Amlodipine is broken down in the liver by an enzyme called CYP3A4. That same enzyme processes a long list of other common medications, including certain antibiotics and antifungal drugs. Grapefruit juice affects this same pathway as well. When something interferes with this enzyme, amlodipine can build up in the bloodstream at higher levels than intended, which can intensify side effects like swelling, dizziness, and the associated fall risk. Metoprolol carries its own interaction concerns. When it's combined with certain other heart medications or stacked with additional blood pressure drugs, it can push the heart rate down to levels that feel genuinely unsafe. Fatigue can become more pronounced, the risk of fainting increases, and the safety margin narrows in a way that's easy to miss if nobody is looking at the complete medication list as a whole, rather than one prescription at a time. This is exactly why a full medication review, looking at everything you're taking together, not just each pill in isolation, is one of the most valuable conversations you can have with your doctor, especially if you're taking more than 2 or 3 regular prescriptions. Many pharmacies now offer what's called a comprehensive medication review, and for someone managing 4 or more prescriptions, it's worth actively requesting one at least once a year, even if nothing about your health has obviously changed. Sometimes the interactions that matter most build up so gradually that neither the patient nor the doctor notices the pattern until something forces the issue, like a fall, a fainting spell, or a lab result that doesn't quite make sense. There's another layer to this that doesn't get discussed nearly enough, and it's the role of over-the-counter products. Many older adults take common pain relievers, allergy medications, or supplements without ever mentioning them to their doctor because they don't think of them as real medications. But certain over-the-counter pain relievers, particularly the non-steroidal anti-inflammatory type, can actually work against blood pressure medications, making them less effective and putting additional strain on the kidneys. Certain decongestants can raise blood pressure directly, working in the opposite direction of what your prescription is trying to do. None of this means you can never take these products. It means your doctor and pharmacist need the complete picture, including the things sitting in your bathroom cabinet that never made it onto an official medication list. Let's also talk about something that rarely gets mentioned in these conversations, which is how lifestyle factors interact with both of these medications. Diet, hydration, and activity level all influence how your body responds to blood pressure treatment, regardless of which drug you're taking. Dehydration, for example, can make the blood pressure lowering effect of either medication feel more intense, increasing the risk of dizziness or lightheadedness, particularly in warm weather or after a stomach bug that causes fluid loss. Alcohol can amplify the blood pressure lowering effect of both drugs as well, sometimes unpredictably. And regular physical activity, even something as modest as a daily walk, has been shown to support better blood pressure control over time, which can sometimes allow a doctor to use a lower, gentler dose of either medication than would otherwise be needed. Sleep matters here too, more than most people realize. Poor sleep quality, and in particular undiagnosed sleep apnea, is strongly linked to blood pressure that's difficult to control, no matter which medication is being used. If you're on one of these drugs and your blood pressure readings remain stubbornly high despite consistent use, or if your fatigue seems disproportionate to what would be expected from the medication alone, it's worth raising the possibility of a sleep evaluation with your doctor. Sometimes the medication isn't the problem at all. Sometimes it's working exactly as intended, and the real issue lies somewhere else entirely. So what do the actual clinical guidelines say about choosing between these two medications? Major cardiology and hypertension guidelines, including those from leading cardiology and hypertension associations, generally agree on one core principle. Blood pressure targets need to be individualized for each patient, not applied as a blanket number for everyone over a certain age. For a healthy, active older adult, a lower systolic target is often the goal. For a more frail older adult managing several conditions at once, pushing the numbers too aggressively low can sometimes cause more harm than the elevated pressure itself, particularly through dizziness and fall risk. Within that framework, the two medications tend to occupy different roles. Amlodipine is commonly positioned as a first-line option for older adults with straightforward high blood pressure and no significant underlying heart disease, largely because of how directly it addresses arterial stiffness. Metoprolol tends to be reserved for situations where the heart itself needs targeted support, such as a prior heart attack, diagnosed heart failure, or a specific heart rhythm condition, because its heart protective properties become genuinely essential in those cases. The key takeaway is that neither medication is declared universally superior in the guidelines. The right choice depends entirely on the underlying reason your blood pressure needs to be managed in the first place. And that's a decision that has to be made with your full medical picture in view, not a generic answer that applies to everyone. So let's return to the real question behind all of this. Between amlodipine and metoprolol, which one is actually safer for someone over 60? Here's the honest answer. Neither one is inherently safer in every case. The right medication is the one that matches your specific heart, your specific arteries, and your specific health history. Amlodipine tends to be the stronger option when the main issue is high blood pressure driven by stiffening arteries without an underlying heart condition that needs separate protection. Metoprolol tends to be the stronger option when the heart itself has already been affected, when rhythm needs to be stabilized, or when reducing the heart's workload is the priority. But understanding this isn't enough on its own. What actually changes outcomes is walking into your next appointment ready to have a real conversation about it rather than simply accepting a prescription without context. So here are 5 questions worth writing down and bringing to your next medication review, whether that's for one of these 2 drugs or any long-term prescription you're managing. First, based on my full health profile, is this medication genuinely the most appropriate first-line option for someone my age, or is there a reason I'm on it that I haven't fully understood? Second, what side effects should I be watching for in the first few weeks, and at what point should I actually call you about them, rather than waiting for my next appointment? Third, has my complete medication list, everything I'm currently taking, been reviewed together for possible interactions with this prescription? Fourth, what is my actual target blood pressure, and has that target been adjusted specifically for my age and overall health, rather than a generic number? Fifth, how often should we reassess whether this medication is still the right fit for me, and is there a point where lowering the dose or switching medications should be back on the table? Any physician who takes your care seriously will welcome these questions. They won't see you as difficult, they'll see you as engaged in your own health, which is exactly the kind of patient who tends to get better long-term outcomes. It also helps to keep a simple written record between appointments, rather than relying on memory alone when you're sitting in front of your doctor. A small notebook or a note on your phone with your home blood pressure readings, your resting heart rate if you're on metoprolol, and any symptoms you noticed and when they happened, turns a vague conversation into a precise one. Instead of saying, "I've been more tired lately," you can say, "I've been more tired since about 3 weeks ago, and my resting heart rate has been sitting around 52 instead of my usual 65. That kind of specific information makes it far easier for your doctor to tell whether what you're experiencing is an expected part of the medication working or a sign that something needs to be adjusted. It's also worth remembering that switching between these two medications or adjusting either one is never something to attempt on your own, even if you've heard that a particular side effect resolved for someone else after a change. What worked for another person's heart, kidneys, and full medication list may not translate to your own situation at all. The value of understanding how these drugs work isn't so that you can self-diagnose or self-adjust. It's so that the conversation with your doctor becomes a genuine two-way discussion, where you can describe what you're experiencing with precision, ask informed questions, and understand the reasoning behind whatever decision you make together. If there's one thing worth carrying away from everything we've covered today, it's this. A blood pressure prescription isn't something that should simply run on autopilot for years without review, especially as your body continues to change. It deserves your attention, your questions, and a genuine partnership with the doctor managing your care, one that takes into account who you are today, physically and medically, not just who you were when that prescription was first written years ago. This video is for general educational purposes only. It is not medical advice, and it doesn't replace a conversation with your own physician, who knows your full history, your other medications, and your specific health needs. Please never start, stop, or change the dose of any blood pressure medication without first talking to your doctor. If you're currently taking amlodipine, metoprolol, or both, and you have questions about your own situation, the right next step is a conversation with the physician who knows your case, not a decision made from a video alone. If this helped you understand your own prescription a little better, I hope it gives you the confidence to ask more questions at your next appointment, because that conversation is genuinely the most powerful tool you have in managing your health as you get older.